Good afternoon. It's fantastic to be here. It's one of the highlights of my year to come and meet everybody, and it's a real privilege to be opening the conference. And I've selected a few things that I think have been significant over the last 12 months to talk about. And the first one is bananas, because there was a bit of coverage in the Daily Telegraph earlier this year. In fact, it was just about a month ago. But what it showed was that this was a bit of research with women after menopause, showing that actually those who ate most potassium, and bananas are full of potassium, were 12% less likely to have a stroke than those who didn't get that potassium. And although that was with a particular audience, it does indicate that bananas, along with all other fruit and veg, very good for you. So a little bit of research that's just happened. Then there's fast. This is very familiar to us, but what's fantastic is that Public Health England continue to fund this advertising campaign, and we saw in February and March these adverts appearing again on our bus stops and on our television screens, and it's really important that that continues, because we know that this type of advertising message, it sticks in your brain for a bit and then you start to forget it. If you know about stroke, it will stay there. If you don't know anything about stroke, then you'll start to forget it. Awareness of what fast means goes down. So the more often that we see those adverts, the better. And if you want to write to Public Health England and say, these are really brilliant, we hope you carry on funding them, that would really help, because that's what we're saying to them all the time. Statins. I don't know about you, but I take statins every day to control my cholesterol, but there was a little bit of a flurry in recent months, because there were some people saying that the risks of statin, the side effects, outweigh the benefits. Actually, that looks like that was rubbish. It was one of those scare stories that you hear. Nevertheless, it's worth reminding ourselves that actually the research shows statins really do lower our risk of having any cardiovascular disease. So despite the scare stories, just keep taking the tablets. And I don't know about you, but I don't find that the side effects are particularly strong. I think they were very much exaggerated in the media coverage around statins. And then we've got thrombolysis, another scare story recently. I don't know if you saw this, but this idea that somehow the risks associated with giving people clot-busting treatment outweighed the benefits. This is because there is an inherent danger in giving somebody a drug which is going to dissolve blood clots and make the blood much thinner. It does mean there's a risk of a hemorrhage, of a bleed. And, but that, again, in this sort of scare story was overemphasized, because all the evidence shows that actually thrombolysis is making an enormous difference to tens of thousands of people every year across the world who are recovering much more quickly from their strokes, because their stroke has been stopped dead in its tracks through an injection of this drug. So, scare stories, we have to be very vigilant, and it always strikes me that you get these types of scare stories when the publicity and the knowledge about a particular condition or a particular drug is very strong. That's when people come out from under the carpet and start sort of saying, hold on a minute, there's a conspiracy going on here, or hold on a minute, this isn't all it seems. Well, I'm absolutely convinced that the evidence around statins and around thrombolysis is really strong, and it's important that we're able to say that to all the people we meet, and that we're confident that actually these scare stories don't have any really real basis. Another really very positive development this year has been robots. And this is because North Tyneside General Hospital is actually one of the first hospitals in the country to actually bring in these robots, and they're to help to the physiotherapy process of bringing mobility back to the upper arm, I think it is. And this is really important, because this looks like being one of the possible futures for rehabilitation physiotherapy for stroke survivors, and to have that in hospitals is a really brilliant first step. It's part of a research program, and research into therapy is much harder and much more expensive to do than research into drugs, because with drugs you give someone a placebo, or you give them the drug and no one knows which one's which, and you look at what the difference is. But of course, if you strap someone into a robot arm, where's the control? Where are the people who aren't getting that? And is it ethical not to allow people the benefit of this? So it's much more difficult to do this research, and it's fantastic that we've got hospitals in this country that are starting to take on that research. And I hope that the results will mean that actually the benefit of this type of therapy will be evidence-based and proved, and we'll see the spread of this use of physiotherapy across the country. Just want to say a little bit about awareness and about social media, because the Stroke Association is very keen to widen the number of people who engage with us and with us as a stroke community. And this is something that we put out on Facebook, and it's just an awareness thing. And it's just really trying to let people know that there are 1.2 million stroke survivors in this country. Everybody probably in the country knows someone who's been affected by stroke. So this was just a way of trying to reach into people who are very familiar with football. And it's just saying that stroke survivors in the UK could fill every top-flight football stadium and there'd still be 80,000 people queuing outside. It just gives a visual image to people about the extent to which we are a community that really needs to be taken notice of. And this is what we call an infographic. It doesn't really mean very much, apart from we're trying to actually get something across with our logo and our brand and our colours, and also with those illustrations. And it certainly got a really good take-up when we put this out earlier in the year. Then there's the issue of benefits. This is from the Daily Mirror. And I expect that you've all come across issues that people are facing around claiming disability benefits, the changes that are going on to the whole benefit system, and the huge delays that people are facing, both in getting their claims processed and in getting their appeals seen. And what we wanted to do was to really highlight this, to put the pressure on, to make sure that the system improves, that people don't have to appeal again and again, and that people don't have to wait so long to get the benefits which are their entitlement. I have to say that this is a long-running thing, and people are still finding terrible delays, and it's really worth making sure that where we can, we support individuals who are needing to claim benefits. We support them to make an appeal if they don't actually get the right assessment at the first time. The appeal system seems to indicate that a very large majority of people who appeal win their appeals. In other words, the initial assessment isn't always very accurate. And then there's the work we've been doing around transient ischemic attack, a funny turn. And I wanted to give you just a couple of examples that we used in our campaign that we launched in May. And this is Bob, and his quote says, "I felt a sudden numbness in my left arm and couldn't get my words out. I had to sit down. I'd seen the fast ads and it immediately came into my mind that I was having a stroke, which was frightening. But it was over within 30 seconds. Tricia and I talked about whether we should do anything or just put it down to a funny turn. In the end, Tricia called a doctor friend. She advised him to call their out-of-hours GP, who dialed 999. The emergency response was amazing." So here's Bob, who initially did what so many people do, and that is ignore the warning signs. Thankfully, in the end, they did the right thing and they got a brilliant emergency response. He got the treatment and he saw the specialist, and his risk of having a major stroke was therefore lowered dramatically. And here's Martin. "My wife Merle noticed that my left eye and mouth was sagging. We both immediately thought of stroke because the symptoms are so well publicised. Merle dialed 999 and the ambulance arrived in 5 minutes. He saw a consultant within an hour, and then after several tests was diagnosed with TIA." So that shows actually what should be happening. It also shows the power of those fast ads and why it's really important that we keep them going. And when we were speaking to Public Health England, who fund those fast ads, one of the big messages we said was, you've got to make sure that this mentions mini strokes, symptoms that don't last for very long, because it's just as important for people to act on those TIA symptoms as it is on the symptoms of a major stroke. So that was the campaign report that we launched, and it got a lot of really amazing coverage. And a lot of people said to us when we were planning this, well, TIA, it's not going to be a really major subject, is it? And yet, we felt it was really important to talk about TIA because there aren't that many, in fact there are hardly any, this is probably the only major warning sign that a major stroke may be on the way. So it's really important that actually people understand what a TIA is and don't dismiss it as a funny term. The publicity we got was very well received. And this is Peter Rothwell, and he's one of the foremost researchers into TIA. We've given a lot of funding to him and his colleagues to really understand TIA, and it was he who recognised that you could work out who was most at risk and when that risk was most acute. It's the first 48 hours after you have a TIA. His recent research shows that aspirin is absolutely a vital part of the immediate treatment for anybody who's having a TIA. He was even suggesting that relatives should give an aspirin, which is a bit difficult for us to advocate because we always say that it really should be a medical professional. But he's just shown through his research that aspirins make an enormous difference in reducing your risk of stroke straight after a TIA. So that's really important research for us. And aspirin is this sort of miracle drug, isn't it? It's used to treat Kawasaki diseases. I had to look it up. It's a disease that young children get. It's a fever. It's an infection of some sort. It lasts a few weeks, but aspirin is the main treatment. But of course it's there for rheumatic fever, rheumatoid arthritis, inflammatory diseases, pericarditis, fever, pain, and headaches. It's an absolutely familiar drug. It's actually a sort of herbal remedy. I don't know if you know, but it was originally made from the bark of the willow tree. There it is. It's an amazing drug, and lower doses of aspirin, as we know, can reduce the risk of heart disease and strokes, and even, it looks like, some cancers. But aspirin has traditionally been something that doctors have prescribed if someone has atrial fibrillation, an uneven heartbeat, and it doesn't work. And the new guidelines from NICE, that's the National Institute for Health and Clinical Excellence, which really sets out what health practitioners should be doing, what the evidence base is for what they do. It says aspirin does not reduce your risk of having a stroke if you have an uneven heartbeat. Very, very clear. And yet the latest information from the first quarter of this year from the Stroke Sentinel National Audit Programme, or SNAP, which you may have heard about, which is a brilliant source of data about stroke and about how stroke patients are treated in hospitals. But what that shows is that of the people who came into hospital with a stroke related to atrial fibrillation, 39% were being treated with aspirin, which doesn't work. And almost 25% weren't being treated at all. So only around a third of people were getting the right support for their AF, and that is anticoagulation. It's warfarin, or it's some of these new oral anticoagulants. This is something that we've really got to change. Every stroke that could be avoided should be avoided. And the thing about strokes related to atrial fibrillation is they are avoidable. It's not quite the same as preventing or lowering your risk of stroke by eating those bananas and taking that exercise. This is something where actually you can trace what's happening. And so many stroke clinicians and consultants that I talk to, for them one of the most heartbreaking things is when someone comes into their stroke unit with a stroke, a severe stroke caused by atrial fibrillation, which, had that atrial fibrillation been treated properly, may not have ever happened. So I wanted to then go on to talk about childhood stroke, because last year, Anna Panton, who's running our childhood stroke project, I think she ran a workshop or maybe did a plenary here, and there was a lot of requests for a follow-up. So at the last minute, she's provided me with this information to let you know what we're doing around children and stroke, and particularly around the project which is running out of the Evelina Hospital, which is part of St Thomas's in London. And over the last year, over 100 families have had contact with the Child Stroke Support Service for information, for advice and for support. And we ran a Parent Support and Information Day in London this year. In fact, we didn't run it, it was parents who ran it. We just supported them in doing so. And we hope to run 2 more in the coming year, one in Birmingham, one in the east of England, so that more and more parents and people who know children who've had a stroke can actually get the benefit from talking to other people, which is exactly what stroke clubs do, but with childhood stroke being rarer, we have to bring people together in a slightly different way. We're also doing a bit of research. We want to identify the needs of families and young people after stroke in childhood. And so we're actually recruiting families to take part in that research through the Evelina London Children's Hospital, through the Great Ormond Street Hospital, and through the Bristol Children's Hospital. And this is really important for us, because we know from talking to people what information and what support people need, but it's this research which actually provides us with the evidence to argue that every family and every child who's affected by stroke should get this type of support. We've got a workbook, which is something we're developing so that we can actually provide a resource to help children and young people understand what's happening to them, whatever their age, and that workbook will be tailored for their age. So that's something to look out for. And if you want to know anything more about this work on children and stroke, there's the page on our website, and Anna Panton, those are her contact details. I think you'll be able to have this handout, you'll be able to get hold of the slides for this, so you don't necessarily have to write it down now. One other thing to say about childhood stroke, and that is it's a bit different from adult stroke. The causes of childhood stroke are different. Many, many more children have hemorrhagic strokes rather than ischemic strokes. So there's not so much that we know about what causes childhood strokes, nor do we have a lot of evidence about what the best treatment is. And because there are only 400 to 500 children a year who have a stroke, they're too far spread for there to be a realistic idea of them getting onto a stroke unit quickly. So there are a lot of issues around how paediatric neurologists treat childhood stroke. And that's why one of the bits of work we've been doing over the years is to try and bring together all the people who can make a new childhood stroke guideline. We've got stroke guidelines for adults. Some of them are done by NICE, some of them are done by the Royal College of Physicians, but they are the blueprint for the treatment you should get at every stage of your stroke journey. The last time this was done for children was in 2004, and boy have things changed since then in terms of evidence, in terms of knowledge of these things. So we want to see a new set of guidelines. We've got the Royal College of Paediatrics and Child Health on board. We've got the Royal College of Physicians on board. All we've got to do now is raise the money to make it happen. And that's what we're going to do. So look out for announcements in the coming year for work starting on a comprehensive set of guidelines for how childhood stroke should be treated. So a lot of things we need to take action on. And for me, I'm Director of External Affairs at the Stroke Association, so a lot of what we do is about trying to get other people to act, or get all of us to act together, to act as a community. It doesn't matter whether you're in a stroke club, whether you're a stroke researcher or a clinician or a physiotherapist, whether you're a family member of someone who's had a stroke. Taking action is really what's going to change the world for the better for people who've had a stroke. And I just wanted to give you a couple of, I think it's 4 quotes from people who've gone onto our website and told us why they're taking action. So we've got Jan, who says, I take action on stroke because it has taken my lovely man away from me and I want the real him back again. Or Mauricio, I take action on stroke because not being able to play PlayStation is not cool. Timothy, I take action on stroke because I'm still here and would like to be heard. And Barbara, I take action on stroke because I know people who have had one and I can help them by telling them things like it's normal to be depressed after a stroke and normal to feel strange about familiar things. I can also reassure them that functions they have lost may return in time. Somehow they are more convinced because I have been there. It's a real privilege to be in a room full of people who are taking action on stroke. You're already doing it. And the more that we can coordinate that, the better, and the more impact we can have in improving stroke services, stroke care and stroke support, and crucially the understanding of everybody else in our communities. So what do we need to take action on? Well, I've mentioned atrial fibrillation. You know, just actually making sure that our local GP is not prescribing aspirin anymore and is looking at proper anticoagulation treatment. But I thought it might be quite good to look at the National Stroke Strategy, which, if you remember, was published in England in 2007, the end of 2007, and there are similar strategies and plans in Wales, in Scotland and Northern Ireland. And the English one is set out 20 quality markers of what would make a good stroke service and stroke support around the country. And in the last year, we've done a bit of work just to look at how far we've come, because we've only got, It's a 10-year strategy, so we've got 3 years left, and we've got a general election coming. Time is getting short to actually complete the implementation of that strategy. So what were those quality markers? I'm going to whiz through some of them. First one was raising awareness of stroke, and I mentioned FAST. They're doing a pretty good job on that, although I think we could have heavier weight advertising and more often if it was my decision. Stroke prevention. Well, we've got annual health checks. I don't know if you've had your annual health check, but they seem to be a bit patchy. Nevertheless, they are there, and they could be a really good way of alerting people to the fact they may have a high risk of stroke. There's Change for Life, which is a government project to try and get people to do more exercise and eat healthily. There's the atrial fibrillation guideline from NICE, which I mentioned. There's the creation of Public Health England and public health directors in every local authority, and there are local public health organisations now. Are they making a difference? Do they have the right budget? Are they reaching the right people? These are the questions. It's actually questions that can't be answered yet because the system is too new. Then there's the need for people to get information, advice and support, which from our experience, I don't know about yours, is really hit and miss. The Care Quality Commission did do some research a couple of years ago that's noted there had been some improvement, but there's still a long way to go. Then there's involving individuals in developing services. I don't know if, to the extent to which you're invited in to talk about the stroke services in your area. But this does happen in some areas, but your experience would be really useful for us to find out about, because we know that the real experts are the people who've gone through the system, who need the support and who know what's missing and what should be provided. Then we go on to TIA, and there were 2 quality markers for TIA, for mini strokes. But despite the fact that people should be assessed quickly, it's absolutely clear that it's not just individuals who have dismissed their TIA as a funny term, but there are plenty of GPs who still tell people to go home and have a cup of tea and see how they are in the morning. And that's got to change. And then it's also about making sure that they're followed up, they're referred very quickly. And that's about that GP referral, but it's also about making sure that in your area there is a TIA clinic that's operating, every day of the week. So that if you have a TIA on a Friday, you're not waiting until Monday, more than 48 hours later to actually get that assessment. If it's urgent, if you're at high risk, you need to be seen within those 48 hours. Okay, then there were 7, 8 and 9. They were all about emergency and acute care. And I've lumped them together because we have seen the most progress in that stroke strategy has been around what happens in the hospital. We've seen the rise of really good stroke units. We've seen the length of time it takes for someone who's had a stroke to get onto a stroke unit shorten. We've seen the time that people spend on a stroke unit lengthen. All those things are very positive. We've seen the spread of clot-busting treatment of thrombolysis. So there's been a transformation. But that transformation is a hard pill to swallow if you happen to live in an area where they haven't done that transformation. Where if you happen to have your stroke on a Friday evening, you have to wait to get into the stroke unit. You've got no chance of getting a brain scan because it's not a 24-hour-a-day service. So there's still a lot to do, but that's where we've seen the most progress. And then there's high-quality specialist rehabilitation. The idea is that everybody in hospital should get at least 45 minutes of therapy a day, of each therapy. That's been actually quite a challenge, I think, for the hospitals, for the physiotherapists, for the stroke consultants to organise, and yet they're making progress towards that. But when it comes to getting rehabilitation in the community, it's still often an impossibility. I just wanted to show you a couple of stats here. So that the NICE guidelines say minimum 45 minutes of active therapy for a minimum of 5 days a week at a level that enables the patient to meet their rehabilitation goals for as long as they continue to benefit from the therapy and are able to tolerate it. But only 12% of stroke patients are currently getting this. So that's something for us to be very active on. And the lack of physiotherapy support in the community, speech and language support in the community, is another thing that we need to really get active on. Okay, here are the next 10, and I'm not going to go through them all because I haven't got all day. But think about what your knowledge is of whether or not things are improving in these areas. End-of-life care, the seamless transfer of care from hospital into the community, long-term care and support, something that we're all intimately involved in this room, assessment and review. Who's getting their 6-month reviews? Are they getting a review after a year? Are they getting another one after a year? And if they're getting those reviews, does it mean that they actually are getting a door opened back into more therapy or more support if they need it? Participation in community life. Stroke clubs are an absolute essential part of that. But to what extent are you actually included in that stroke journey, in the planning for the long-term support of stroke? You need to be. Return to work. This is always a very difficult issue, and it's one which I don't think has been cracked at all. What type of support, what type of rehabilitation, what facilities do people need to enable them to get back to work, get back to independence? Stroke networks. The strategy created, I think it was 29 stroke networks around the country, but in the new NHS they've been abolished. So what do we do about that? Well, there are now 10 strategic clinical networks, they're called, and they cover much more than stroke. They cover a whole range of different issues. And yet these are what we've got left, and we've got to actually work with those networks to try and make sure that they are focusing on stroke and they're doing all the things that they can to help to improve stroke services in every area. And then there was the quality markers on the workforce, leadership and research. We know that we're heading for a crisis in terms of the number of stroke consultants and clinicians there are. There's a whole swathe of clinicians who are reaching retirement. Have we got the new younger people coming into the stroke field, specialising in stroke, who can take forward that care? We know that there are huge training needs for people who work in residential care and care homes who don't know anything about stroke, and yet a very large proportion of the people they're caring for are stroke survivors. There's a huge area of work to do here, and this is something which really there's been much too little progress on. And then there's research. We have seen over the last 5 to 10 years a really welcome increase in the amount of money this country invests in stroke research, but it's still dwarfed by the amount that goes into research for other conditions like cancer and heart disease. We've got to see that change. We can't do that research if we haven't got those researchers out there, so we need to nurture those researchers as well. A lot of work to do around research. Just wanted to show you this map of the regional differences in the incidence of stroke, and this is because this year we gathered together all of the stroke statistics we possibly could, and we're hoping that they'll go live on our website in 2 or 3 months, perhaps after the new year, and it's really everything we could find out about stroke. And this was one of the ones which struck me as being one of the things that isn't said often about stroke. And it's actually that the poorer you are, the higher at risk that you are of having a stroke. And the poorer you are, the more serious your stroke will probably be. In other words, deprivation is one of the major risk factors for stroke. And people from the most economically deprived areas of the UK are twice as likely to have a stroke than those from the least deprived areas. The darker purple is where those deprived areas are. And people in those deprived areas are 3 times more likely to die from their stroke than people from the least deprived areas. So when we hear about a society that we live in that's becoming more unequal, this is one of the consequences of it. And it's having real health consequences. So it's just something for us to think about when we're thinking about risk factors for stroke. And I mentioned stroke research. Here are some of the statistics. So £23 million is spent on stroke research each year. And this is just a comparison. So £590 million is spent on cancer, £169 million on heart disease, $50 million on dementia. And you can see the graph at that bottom that it's really time that stroke caught up. Stroke has just as much of an impact on our society as those other conditions. It's been neglected for much too long. So that's something which we can take action on. And at the Stroke Association, we've got a proud record of funding research. £2.5 million a year. I think it's around £40 million over the last 20 years that we've invested in stroke research, and that research has made a huge difference, including the research that led to those fast adverts. So, you know, we can make a difference with that research, but we just need to see much more, and we need to see those big funders of research, like the Medical Research Council and the Wellcome Trust, actually prioritising stroke more. So, action. This is a rather badly taken photo by me of a new document that we put together, and this is really to try and give you, as well as parliamentary candidates, the tools they need to have the conversation about stroke in the run-up to the general election. So I'm not sure if we've got any copies here. Patrick, have we got any copies here? Okay, so they can be ordered from us, and if you just drop us a line, drop us an email, I'm sure that we can send some out to you, because this is the way of actually starting the conversation with those people who are going to represent us after the next election, and they're going to have maybe 2 years then to complete the work of that national stroke strategy. So together we can conquer stroke is that phrase that we really want to use to galvanise the action that I'm talking about. And I think this word together is really important. It's great that we're all together here today over the next 2 days, because actually working locally, working nationally, that's the way that we have improved care, and it's the way we'll continue to do so. We need to work together to provide better, more support for the stroke survivors in our community. And we can build a really strong stroke community. That's of stroke survivors, but it's connecting them with those stroke clinicians, those physiotherapists, those researchers who are also in our community. And together we can conquer stroke. Who would have thought that we could reduce mortality rates from stroke from around 33% 10 years ago to under 20% now? We've done that, and we can do so much more. So thank you. Thank you for all the work you're doing that makes such a huge difference. Thank you for the amazing support you give to stroke survivors. And let's go on and make sure that next year we've got an enormous difference to report over the, for the 12 months that are just coming. And of course, remember, eat more of these.